Time to get going with our conference with the inaugural session, which is entitled Setting the Context, Building Health Systems for Universal Coverage. And we have three distinguished guests I want to thank for bringing us together, actually, because they're among the core sponsors of this event. And I want to use this opening session to help them set the scene as to why we're here and what we hope to achieve as we talk for the next 20 or 30 minutes. Unfortunately, our fourth member from the in the agenda list, Dr. Rajiv Modi, who represents the Federation of Indian Industry, couldn't make it, but we do appreciate his continued support. So I'm going to ask our distinguished panelists up on stage to join me. Professor Helmut Brand is joining us, please, the Jean Monnet Professor of European Public Health and the head of the Department of International Health at Maastricht University, also the president of the European Health Forum, Gastein. Good to see you, sir. Thank you, sir. Ms. Ranjana Smethacek is the Director General of the OPPI, the Organization of Pharmaceutical Producers of India, and also a council member of the IFPMA, the International Federation of Pharmaceutical Manufacturers and Associations, which is based in Geneva. Please come on up, man. Okay, good. Come on up, thank you. And we also have with us Mr. Richard Bergström, who's the Director General of the EFPIA, the European Federation of Pharmaceutical Industries and Associations. Welcome. Good to see you. So really, we do want this to be interactive. I'm going to kick off with a couple of questions to each of them, but please feel free to put your hands up. We've got microphones around the room we can get to you, so you can join in as well. But let's get the context going initially, and I'm going to actually, I'll start, if I may, here, ladies first. I'll start with Ms. Ranjana Smethacek and ask really to give us a perspective on the state of affairs in India, because we're looking at Europe and India to a large degree here, but give us a sort of scenario on the situation, please.
Thank you, Riz. So I think the past year, so I'm just going to try and give you a snapshot of what these last 10 or 11 months have been like. We had a brand new government, came into place last May, and I think they really spelt hope for the entire populace of this country. So for us in the healthcare sector, we were very encouraged to see that the government was going to prioritize healthcare very soon. In the early days, we were told we are looking for, we are hoping to have national health assurance for all. Basically, this was going to be a basic level of health insurance for everybody. And though we didn't see any sign in the interim budget last July, we said, it's early days yet, it'll come together. More recently, I've been a little bit discouraged, not entirely discouraged, a little bit discouraged with some of, if maybe it's not too strong a term to say, some backtracking. So in March, we were told that we are not really going to be able to focus on, the brakes are going to be pressed on the National Health Assurance Mission. In April, we were told that the promise of free medicines made available by the center not going to happen. It'll be a responsibility of the states to work with their own budget. Most relevantly, Riz, in February, when we saw the first full budget from the new government, we did not see the word medicine or drugs or devices, medical devices. So all of this is a worry for me, because I think all of us who work in the healthcare sector, we know that if the first level of commitment to prioritizing healthcare has to be sort of assigning some budget to this. So to say that we have a 2% increase in the health budget, which is way below the inflation, is a worry. And I just want to take another moment, if I may, to say that, if we just look at what healthcare entails, we had, clearly it's more than the price of medicine. It is the infrastructure, the functionality, quality of that infrastructure, and finally, the affordability, which could be the price, it could also be the ability to pay. So that's why insurance is so important. So I'm hoping that, I think all of us in this country are looking for, and I quote the Times of India, looking for intent now to be translated into actions. This is the place where we are now, Riz. So I was
going to ask you, based on this kind of, so far, what seems to be failed promises, or the risk of failed promises, do you anticipate any kind of proper backlash for this failure, or is it going to be something that slips under the radar as kind of electioneering promises that never really materialized, as always?
So I think I think it's credit to the Ministry of Health that they came up with the draft policy last December. It was a very sort of idealistic kind of a policy. It painted this picture of the perfect world and how it should be, and a little bit less on how we would get there. But I think it was a good step. They did come up with a 5-year plan and a 5-year budget, which has gotten turned down. But I'm hoping that basis that policy, government will still say, okay, maybe we can't take all of it in 5 years, maybe a little longer. Can we take first steps? So I remain hopeful. And I know that our Prime Minister, in the conversations he's been having in several countries around the world and with visitors here, clearly this continues to be something that exercises him. Am I holding my breath? Not quite.
Okay.
So.
Well, Professor Helmut Brand, if I could welcome you and also ask you, I mean, one of the things that Ranjana has mentioned here is the issue of how it's the sort of responsibilities being devolved to the states. This compares in a little way with Europe, which of course has its kind of federalist environment. Let me ask you first of all to set the scenario for what we could do at this conference when we look at EU and India, and what you hope will come out of it.
Yeah, India and Europe have a lot in common. When we often talk about European problems, a problem of federalism, and you share the same problems. What should be dealt with on which level, and who should be in charge of what. The other issue is that we are under new management too in Europe. We just have a new commission now, and again the question, what will be delivered now? And there are some signs that the new boss of the commission wants to see a little more about health systems performance assessment. So what do we get for our money and how it's organized? So I think the underlying concepts are the same. There is one big difference. Europe went through times of financial crisis, so there is some experience how health systems can deliver or not deliver when suddenly the shock waves go through Europe. And that is something where we have a kind of laboratory with 28 different states, where you can see how the different approaches lead to different outcomes, or maybe not. So that is something where we really can have a nice discussion about what are essentials to make a health system weatherproofed, especially for India.
Do you see an easy transfer of the experience of Europe to India?
Well, we have problems in transferring our experience in Europe between the countries, and there seems to be an art and science of comparing health systems to find out what really makes them unique and what are the good examples. And what I learned over the last years is that, for example, cultural issues are even as more important as just what kind of system you have. And if I may tell, in Europe we had the history of two competing systems, one health insurance based, the Bismarck model, and the National Health Service beverage based, and people tried to split up everything in two parts, either this or that. But what we see in the last year, that we get more to a Bitheridge or Bevermark system, where those boundaries blur, because in the NHS they introduce more and more issues that are from health insurances. Money follows the patients, you can get outside the service. If the waiting time is too long, you decentralize. And in the classical insurance-based systems, we see suddenly state money coming in via taxes. So it's not a clear division anymore. And this makes, on the one hand, the picture not so distinct anymore, but much more interesting.
We have quite a lot to discuss here. I want to get to Richard Bergström here. We have throughout the day 4 sessions essentially looking at various aspects of healthcare, from lessons learned and how to build and design a health system, to regulatory systems, and of course the use and application of big data. I wonder really, I mean, of course the EFPIA has been wonderful supporting this too, what you expect the outcomes to be and what you hope will be the takeaways from these kind of subjects that we're looking at.
No, I think when I look at the program today, and indeed particularly things like big data and other topics, one might wonder and say, why are we going to discuss in India things that, we've not been able to deliver on really, in Europe or in the United States. But as we thought when we made the program, I think it's extremely important to share with an Indian audience, as you are going to invest more in healthcare, to really not only learn from the mistakes, and there's probably more mistakes there to be looked at than successes when we look at Europe, and also not just learn from them, but actually to consider leapfrogging, if I use that term. Basically skipping to the next step, right. Because we invested in IT because we had mainframe computers at one stage. You know, we had PCs. You know, now it looks different. You know, why would you invest in that way? And this is just one example. I think this goes throughout the systems. And as Helmut said about the sort of blurring of concepts in European policy making, it's, in a way, it looks more coherent in a way, because it's sort of the same things are happening in whether it's a German type system or a UK type system. There are similar concepts. There's a strong push towards outcomes, measuring outcomes, paying for outcomes. I mean, all the experimentation going on in the United States as well with payment reforms in Medicare, it's happening in Europe as well within our systems. So it's very important that wherever we go in the world, any country investing in universal healthcare, that they actually try and be at the forefront, whether it's IT, whether it's how you pay for services, how you pay for medicines. I mean, there is a great appetite from the leaders of my industry to be paid for outcomes and not by pills and ampules. Now that's easy to say, very easy to say, but it's extremely difficult to deliver on, and we don't even do this in Europe yet. But to have this in mind when you design the Indian healthcare system, you need to design the primary care, you need to design the secondary care, you need to figure out how to build on your fantastic private hospitals you have, which might be the best performing ones in the world in terms of what you get for your money, right? How does that fit in the system? Because it has to be a health system. So this title of this meeting is not, of this conference is not by chance, you know. One needs to look at this as a system that's being built with the appropriate market component, with the appropriate competition component in there. So I think that's what I hope we can deliver with this conference, is to get to give us sort of inspiration for doing also some things that are the latest or that are new.
Thank you, Richard. Well, we do, of course, have a lot of people in the room with expertise and experience here, so please, let's keep this interactive. Don't be shy. Do put up your hands for questions and comments, and we'll get a microphone to you, and I'll get to the hands in the order they go up. So do get your ideas and your comments ready, because, of course, the idea is for an exchange of information, not simply for us to kind of lecture from the stage. You raised an interesting point, though, Richard, which I'd like to put to Ranjana, which is this issue of leapfrogging. Is India really at a stage where it can leapfrog, or does it have too much of a heavy legacy that is going to take a little bit of clearing away first before the next step?
So I think clearly we have challenges, Riz, and I just want to sort of draw the attention of this audience to, so we asked ourselves these questions about 2 years ago. Industry and others together said, can we understand what access to healthcare for all Indians means? What is the meaning of access to healthcare? And IMS did a study, covered several states across the nation, and I think their findings are very relevant. And in a nutshell, what they found was the first thing they need is proximity. They found that at the moment, 3/4 of all Indians are traveling more than 5 kilometers to a healthcare facility, and 5 kilometers is hard when you're living in rural India. What this means is you spend the money getting there, but you also give up your day's wages. So this was the first big challenge. And obviously this is something which, I mean, the primary health centers, these basic facilities are something government sort of leads. The next thing they found is that the quality and functionality of what you found, finally, when you got to this healthcare facility, was key. So did you have a doctor who was there in time or even there at all? Did you have a nurse who knew your stuff? Was the x-ray machine working, and so on? So this whole infrastructure, its quality, was the second element. And then the third thing was, of course, affordability, in terms of, do you either have the ability to pay, or do you have the, you know, is it cheap enough that you can pay out of pocket? So I think from this, you know, OPPI and others have had discussions around what will it take to make healthcare accessible. And clearly, there are many stakeholders, and Richard mentioned, and there has to be ways of working together, whether it's the hospital owners, the pharma industry, the insurers, and all of this. But I think equally clearly, government has to lead the way. So, that's a little bit of a long-winded answer, but I did want to give this context. I think it's going to be complex. I don't think it's impossible, but I think there's to be, most of the stakeholders, all the stakeholders are willing to come forward and do their part, but they all will have to be engaged. Government will have to be totally committed.
There's a lot of aspects to this issue we'll discuss over the day, from how private and public healthcare systems might interact to how insurance and payments might play a part. So we'll get through that in the day at various stages. We've got the various sessions covering various aspects. I do again want to encourage you to put up your hands, and if you have any questions, please put your hand up and we'll get you a microphone. And please make the most of the experience and expertise we have of the people in the room and right now up on stage as well. While I wait for the hands as well, Professor, let me ask you if this issue of the government's responsibility can be kick-started in some way, so that perhaps the kind of goals that we're aiming for, we're discussing here, might actually be realistic, and realistic in a realistic timescale.
If you're on a rally for election, things look different than in real world. After the election, you have to deliver. And then you are suddenly faced with the problems of bureaucracy, and that your political vision is something not in line what your own bureaucracy thinks what should be done. And that's the reason why such a change in government that India saw recently has a unique opportunity. Because on the one hand, for those who are in charge, they can try now really to put a different focus, and for the administration, they can find again the old plans that were not possible to make reality with the old government, so you take your plan B now. So the most important is to have a vision and some leadership in this. Leadership in public health issues is getting more and more important, because as Jean Monnet, one of the founding fathers of the European Union, said, if you want to see change, you have to rely on persons. But if you want to make them sustainable, you need institutions. So in a way, the magic question that is always asked was, well, what is the best healthcare system that we should strive through? There is no answer to this. So it must be the health system that fits to the needs best. And in a way, it does not matter a lot if you go for insurance-based or NHAs. It's what is delivered in the end. And for example, a country like Taiwan did an exercise several decades ago and reformed their health system, looked all over the world and put a health system together that gets very good marks now and is really fit for purpose. So I think leadership has to come from government, and then you have to find a way where public-private partnerships and so on can be implemented in a way that suits the country and what the people would accept too.
Sorry, you want to add something to this, Richard?
No, I just wanted to comment something you said, Helmut, about bits and pieces. So I think this is important in this global discussion on universal healthcare, that when you look for inspiration elsewhere, that you have to go to many places and you have to disaggregate these systems to build a new system somewhere else. Why I'm saying that is because if you take the US healthcare system, and the prevailing view in Europe is that Europe has nothing to learn from the US, which would be a huge mistake, because we have high-performing health systems in the United States, Intermountain, Geisinger, others, that are a role model for people, or should be a role model for people around the world. You know, they manage to deliver high-quality services to patients. It's patient-centric. They're investing heavily in IT, mobile phone technology. You know, the appropriate use of new medicines and old medicines, and really inspiration. Similarly, in Europe, you can't take a country and say, okay, we go to Sweden, like my home country, and you say, well, because overall Sweden performs well, you take the whole thing and copy that. that would not be a good idea, because there are things that do work well and things that certainly could be improved. And we need to be, as Europeans here, very modest about this. You know, where are we proud and where are shouldn't we be so proud? I had an experience just recently. I was traveling and I met the health minister from outside Europe, and I said, so what are your plans now for switching from a sort of private out-of-pocket market for primary care and medicines and so on. So he said, well, we're going to we're going to copy Austria. Oh, I say, why Austria? Well, because they were here last week and presented. So I say, now I think that, you know, probably in the primary care, I think Austria has done a lot of good work, whereas I know Austrian officials complain all the time about having a too heavy hospital structure. You know, so I think, again, it's very important to look at the different pieces, and that's why, again, the systems approach is important, because you need a primary care component, you need a medicines access component, you need and so on and so forth. And we mustn't forget also, and I hope this is also, we remember this in this discussion, is the prevention component of this. You know, the public health component has to be part of any healthcare system you're building.
Thank you. I'm going to get to, we've got a hand up. If you put it nice and clearly, we'll get a microphone to you. You need to raise it a little higher so they can see you. That's it. Thanks, if you could. Thank you. Do tell us your name and where you're from, your affiliation, please. That would just help get some perspective. Just talk into it first. Try. Yeah.
Ashok Bhattacharya from Johnson & Johnson, based in at our headquarters in New Jersey.
We just need it a little louder if we could, please. A little closer. Yeah.
Okay. Well, anyway, I wanted to sort of build on the comments made by the speakers regarding the fact that there is really no panacea or a sort of a one-size-fits-all.
Sorry, a little closer. It's very hard up here.
Can you? Hello? Can you hear me now? Okay. All right. Now, just saying that I think the comment has been made that there is really no one-size-fits-all formula, and that, you know, some kind of composite hybrid model might be the way. The actual composition of it may vary. It's sort of a fit-for-purpose type of situation. But I think it's important to sort of emphasize that that particular approach, this sort of more eclectic hybrid kind of approach, is particularly important for India, and that, you know, there is the notion, and even in the National Health Plan that I think Ranjana alluded to, there was a suggestion that perhaps, you know, a sort of at least in terms of intent and expansion of healthcare by the government, a la what was attempted in China, for example, and other places, may solve the problem. But the Chinese experience clearly shows us that what was announced with much fanfare about 4 or 5 years ago and heralded by the WHO as, you know, this tremendous accomplishment, has now come to a grinding halt. I mean, as we all know, and they have now explicitly acknowledged that, you know, this one single payer approach, even in China, even despite the massive investments, can't work, and that there needs to be this sort of complementary mechanism, what we're seeing in Europe, in China. I'll wrap up. So that's one point. So I think given that those systems are tax financed and given India's tax, you know, resources, I think it's a tall order to think that that can happen. So again, the need to combine both public investment with private. Right. And the other piece is, until and unless we focus on this and the infrastructure piece, and we will tend to get distracted by relatively less pressing issue. I mean, I wouldn't say, so pricing of things, drugs or devices and so on are important, but no matter how inexpensive they are, in the absence of the infrastructure, the capacity to absorb them, it's not going to solve the problem. So I think that's why I think this is issue.
Ashok, thank you very much. Chris, I'll get you in a second. Actually, I want to put this to Ranjana Smethacek here. This is something the professor had mentioned, the need for public-private partnerships, because, of course, a country the size of India, it's going to take kind of a fairly complex and comprehensive solution. Just listening to what our guest had to say there about this need for a very measured approach rather than the kind of one-size-fits-all. How do you take that?
So I completely agree with you, Ashok. There isn't a quick fix, there isn't a simple fix, but I think, you know, there is adequate experience around the world, there is expertise within our country and overseas, and I know that there are conversations. I mean, I'm hoping that there will be a greater commitment. We've seen this draft policy, it sort of seemed to be halted, but I mean, I'm hopeful that the health ministry will continue to push a little bit more, bringing a little bit more focus on how this will come about. So I think it's a good step to make this vision document, but I think the next step will be how will we bring it about? And yes, it will take collaboration within government and with stakeholders not just in India but around the world. So, you know.
Richard, a quick comment on that before I get next question.
I fully agree. And I want to come back to what Helmut said about the need for institutions. I think that's why we have on the program today, you know, we have the head of the European Medicines Agency here to illustrate that you need strong, probably federal institutions that for certain things, like you need a strong regulatory body for pharmaceuticals, for medical devices, you need strong bodies for inspections of quality of healthcare. And similarly, you also need institutions that can do method development and develop the new tools. We have in Europe something called European Observatory on Health Systems, which unfortunately the director couldn't come. We invited him, which is funded by the Commission and by the WHO European Office, which serves as the sort of big think tank next to European Health Forum Gastein. So you need to foster and stimulate. These are also institutions, but they're not legislative, you know, but they are places that actually can somehow coordinate across public-private partnerships and make sure that there's some kind of direction.
They have the experience that way, yeah. Chris, microphone there. If you put your hand up. Oh, you got it. Good. Okay, thank you.
Yeah, I just want to come back to a point that Ranjan made early on.
Chris, sorry, just quickly tell us your full name and affiliation so
Yes.
people know who you are.
Chris Ward, I'm with Ward Health, which is a health policy consulting company in Canada. I also had 14 years of experience in government in Canada directly related to healthcare, so by way of background, that's sort of where my interest lies. But I want to come back
A little closer.
I'm sorry. I want to come back to the point that Ranjana made and the reference to the work that was done that looked at some of the concerns and the underpinnings of the potential to expand healthcare in India. And it really does come down, or did come down, to issues of quality, functionality, and affordability. And I don't think it matters what country in the world you're from. Those three issues permeate the public debate in terms of the quality of healthcare anywhere. It's impossible to argue that India should not commit more resources, more financial resources to healthcare initiatives. But I do have to say I actually have some sympathy with the government in terms of when it's ordering its financial priorities. If you look at the healthcare system and investment in healthcare system, where do you begin? Do you begin by throwing money at a system that functions poorly? Or do you begin by looking at what are the mechanisms to change and reform that system before you invest more public funds? You know, so for instance, when you look at primary healthcare delivery, the physicians in India are not going to locate in remote communities because they're not going to be able to make the kinds of incomes that they want. Other problems that exist in terms of primary care within the country is the fact that there's no division between prescribing and dispensing. A lot of physicians make as much money from the markup of the products that they prescribe as they do from the fee-for-service. All of those things have to change first before you have a massive investment. And the way to do that, quite frankly, I think is by building and putting in place a proper regulatory structure for the delivery of primary care before you throw money at it.
Chris, I'm going to ask you also to pick up on that point in the next session, which flows into this on the aspect of building a healthcare system and the lessons learned. So that's a very valuable point you made there. So I'm going to ask Ranjana for a quick response, if I may.
I cannot argue with Chris on this. You are completely right. It is about, it's not just about, you can't be throwing money at the problem, but it's about finding this workable system. And I think the workable system doesn't mean necessarily just mandating things which are hard to execute. Like, you know, every doctor needs to spend 2 years in rural India. But then this doctor, he spent all this money getting his education. He's going to be dispatched to rural India where he may not be able to have his children and a wife there because there are no schools and so on. So I think it's a little bit unrealistic. So I think the focus I would bring is to workable, you know, solutions.
All right, thank you. Let's squeeze in one last question before we go to the next session. But again, do keep your questions ready because the next session will flow into this as well. Microphone to the gentleman there. Put your hand up nice and clearly. Thank you. There we go. Yeah, it's okay. Talk into it. Talk into it.
I'm Siddharth Prakash from Medtronic. And I think for any health system to work effectively, you need to have political commitment, and with that will come the subsequent resources. In India, I think the political leadership has always lacked that political commitment. And today with the Prime Minister, I think we see it more than ever before. And unless we have, I think the Prime Minister clearly sees health as an economic burden. And the numbers, that you've got so many NCDs and this will be the cost in the economy. But there's a flip side, which is that healthcare has a tremendous opportunity. If you look at medical technology alone, that's a very small sector, but it's at 5 billion today. It can go to 50 billion by 2025, according to reports by BCG and so forth. And that means more jobs, better health outcomes, and a lot more foreign exchange, and business opportunities for the government. So the question really is there a way that the India-EU dialogue that's taking place here today could actually influence, the Prime Minister's thinking and see the opportunity for business, because he's so keen on Make in India and getting foreign investment, that, healthcare is really also a big avenue and potential to do this. And it is through that investment that, you will get business, you'll get growth, and you will get better health outcomes.
Right, very important point. I'm going to put this to Professor Brand, because what I want to do is also follow up with you on what happens next. Because the conversation shouldn't obviously end here, but how can the points that have been raised here, the potential through the healthcare sector, through the investment in technology and so on, and the opportunity, even things like medical tourism, be exploited? And then where does this forum go next in terms of how it moves things forward?
In Europe, we had a similar discussion 15 years ago where it was a discussion about health and wealth. Is spending money for healthcare just wasted money, it's gone and you never see it back, or is it a strategic investment? And there is some evidence that investment in health and healthcare, especially in public health, really pays off. There are some differences between India and Europe, for example, with the demography. Europe as an aging society, in India you have a different issue. So here you have big workforce being young, and in Europe they are hunting now those people who are still fit for work in, let's say, 10 or 15 years. So it's a little bit a different approach, but there is a lot of possibilities. In my former life, I was the boss of a pharmaceutical control unit in Germany, being in charge of 60 million people and sending inspectors to India to see how the production of generica is done. And they all came back and said, well, they learned their lesson. They have all the necessary accreditations. It's going well. I just visited Manipal University. 300 new pharmaceutical engineers are educated every year there for the generic business, and they argue now we want to do the next step. We want to go into innovative medicine. So there are sectors in health and healthcare where India can leapfrog even more, building on existing knowledge. And I was shown a device for blood sugar measurement that was half of the price of the European products, and they said we want to go to 1/10 of it. Right. So that are things where because this new kind of innovations is available everywhere, you on the one hand have the manufacturing skills, you have the technological skills, and when you look on the mobile health revolution, there are so many well-educated people here that really can take care of new issues that will be solved due to totally new technologies. And that is the big difference to what we saw before. Until now, we are only fixing health systems. Right. But for example, in IT, we had the chance to build something totally new. And we have to get specialists in fixing parts.
Professor, thank you. I'm going to ask for a round of applause for our panelists, please, because we've got to move on to our next session. Thank you so much. Professor, I'll ask you to stay.